Howdy, my name is Garrett Lipinski. I'm one of the Resto POs, and today I'll be teaching you a little bit about trauma. In my presentation, I'll be covering eye injuries, patella dislocations, splinting, as well as C-spine stabilization. So first and foremost, eye injuries. Eye injuries are not life-threatening, so as in most of the injuries we'll be discussing today, your ABCs and vital signs always come first. With the eyes, you really want to stabilize everything. So you do not remove the object from the eye, obviously. In order to stabilize the object that's in the eye, you'll take gauze, put it in the shape of a donut, and put that around whatever object has been impaled in their eye, and then wrap that around the head to secure that in place. So now that the object is stabilized, you also want to make sure the eye has been stabilized. And to stabilize the eye, you will be covering up the other one. Remember, your eyes are connected. They always move together. They should. And so if one eye is covered, one eye is not, and the other eye is looking around, you can still harm the patient. So always make sure to cover up both eyes. Do not put, or a keynote is do not put any pressure on the eye when covering it. Eyes are really sensitive, especially if they've already been injured, and just make sure that the gauze is around the eye and not on it. Here's two photos. First one, see this lady got impaled in her left eye. What they did is they put the gauze pad around the object to help stabilize it. And then with her right eye, they just put a sheet of paper, taped it down. That way she can't look around. That way she's not tempted to look around. With this gentleman here, I don't know what happened to him, but they covered up both of his eyes. Again, he can't look around. His eyes are stabilized, and therefore he's ready to be transported. Secondly, patella dislocations. So patella, for those who forgot, that's your kneecap. Way this will often be presented to you is you'll be showing up to a sports field, etc., and someone will say, hey, like my knee went out or my knee moved. And when you go to look at their knee, you'll literally be able to see that their knee doesn't look like it's in place because their kneecap has been moved out of its general spot. For EMTs, they have two ways we can handle this. One is if we know it's a kneecap injury and everything else is okay, just kneecap dislocated, you can have two EMTs try to put it back in location. The way that will be done is one EMT will grab on the leg, other EMT, and apply traction, while the other EMT slowly pushes the kneecap back into location. However, this can be really painful and the patient might not want it, or you might not know what's wrong with the patient's knee and therefore really it's not beneficial for you to go poking around. If that's either of those are the cases, then what you'd want to do is just split the leg as found and transport to the hospital so they can get further care. So remember, the kneecap can be dislocated either medial, it can go inside, or laterally, it can go outwards. Generally, the kneecap will go laterally. As seen in this photo to the right, you see this guy's knee. Where you normally see a kneecap, you just see nothing. However, you see this odd bump sticking out to his, what appears to be his left side. And that's his kneecap. It was just moved up and dislocated. Musculoskeletal. So splinting. With splinting, again, ABCs is always your first priority. Also, if somebody broke a bone, likely they had some kind of high impact, and so there's really potential that they need spinal restrictions. That way, you don't cause any spinal injuries while transporting the patient. Manually stabilize, oh boy, the injury, both above and below it, and then check for PMS, pulse motor sensory. Yeah, as an EMT, we really want to make sure that the area has blood flow, so we always make sure to check the pulse motor sensory before and afterwards. When it actually comes to applying the splints, there's a few different kinds that we can apply. You have your long and short bone splints, and then you also have your more specialty ones, like your traction splint, as well as your pelvic dislocation brace. Key points to keep in mind is you want to consider any open wound near the suspected bone injury site to be the result of the bone protrusion. Not always. When the bone breaks, it sticks out of the skin, but it is quite possible for that to happen. So types of splints. You have a few different types of splints. These are your long and short bone splints. If you look at the photo on the right, you see 3 different lengths, and those are your general splints. Remember, for these ones, they have their soft side, the foam side, and they have the hard side. The foam side always goes towards the patient. So say the patient has like a tip fracture on their lower leg, you'll be using that long splint, long board, the medium-sized board. Medium one goes on the inside, long one goes on the outside of the patient, and then you just use your A-spring just to secure it to the patient. Likewise, if they have a radius ulnar fracture, so somewhere on the shorter bone, you'll just be using 2 or either 1 or 2 short little splints. and that will just be strapped to the arm, and then that arm, of course, will be supported using a sling and swap method. One unique type of splint, which really isn't a splint though, or just a compression device, you'll do if the person has a pelvis injury. So if the person has a fractured pelvis or dislocated pelvis, what you'll be doing is you'll be sliding a bed sheet underneath the patient and then wrapping it up nice and tight. What this does is this applies compression to the patient's pelvis area, pelvic area. Reason you want to apply compression is twofold. Compression, it reduces the amount of space that blood can fill up that area and bleed. It also just reduces the ability that blood will travel down and bleed anywhere else in the body. So it's a good tool to reduce internal bleeding. Secondly, if the person injured their pelvis, they quite possibly have little bits of bone and such floating around that area. And as you're transporting the patient, that all those little sharp bits are now moving around, it can continue to harm the patient and cut them and such. And so by compressing that area, really isolating it and just preventing any further damage from happening to the patient. Lastly, we have our C-spine. So now that you know a few different kind of injuries a patient can have, we need to know when do we actually give the patient C-spine. That's the cervical collar. So the first question we always ask ourselves is, does the patient meet adult/pediatric major trauma criteria with blunt mechanism of injury? And that pretty much means, was the patient hit really hard by something? If the answer is yes, then you will assume spine injury and give them a cervical collar. The answer is no. You ask yourself further questions, and any of these come back and say yes. Then you again treat the patient as if they have an injured spine. If they have an altered mental status. If they're complaining of neck and or spine tenderness, if they have weakness or tingling in any extremity since the injury, if they have deformity to the spine, if they have a high risk mechanism of injury, so that's like axial loading, high-speed motorized vehicle crashes, if they were walking across the road and they're hit by a car, or if they even fell, anything that's high impact, again, we'd suspect that the patient has a spinal injury. So what do we do with a C-spine or with a cervical collar? So the cervical collar is pictured in the bottom photo here, and you'll notice there's two parts. There's the yellow part and the blue part. The yellow part's the actual cup that goes around the patient's chin. What that does is that's the part that actually you can adjust and supports the patient. The reason it's adjustable is everybody has different lengths necks, and you use the little tabs on the left side of the collar, left and the right, sorry, they're both, to adjust the length. We'll learn how to do that more in person this coming week. So now, once you get the collar, the length of the collar, the cervical collar set up, then what you'll be doing is placing the cup around the patient's chin, strapping it around and securing it to the patient. Only after everything's strapped down, then you can release the manual stabilization of the patient's head. That is all I have today for y'all. So just to recap, we covered eye injuries, patella dislocations, splinting, and C-spine stabilization. If you have any questions, please feel free to reach out to either myself or Ms. Alcorn. I'll be more than happy to help. Thank you for your time, and I look forward to seeing y'all this coming week.